টিকিং মোড তো বন্ধ হলো না।
ও বন্ধ হয়ে যাবে মিটিং শেষ?
হ্যাঁ
ওকে।
এই শান্তা শান্তা এই শান্তা তোমার মাথাটা কি একটা তো
বা কোন জ্যাকেট ভালো হয় মাথা ঠান্ডা
খুশি স্যার আছেন স্যার? হ্যালো সুমন, সুমন কি খাচ্ছো?
না স্যার, হ্যাঁ খাওয়া শেষ স্যার।
স্যার আছেন? স্যার ও
একটু আগে দেখলাম স্যার ছিলেন, এখন তো দেখছি আবার রুমে আউট হয়ে গেছেন। আচ্ছা আমি ফোন করতেছি স্যার।
অসুবিধা নাই, 3টা তো 2:59 এখনো 1 মিনিট বাকি আছে।
আচ্ছা আচ্ছা ঠিক আছে।
লাঞ্চ শেষ প্রেসিডেন্ট স্যার?
তো তাড়াতাড়ি খাওয়া যায়?
স্যার
তোমরা আগের সেশনগুলো কমপ্যাক্ট না করে এখানে এত তাড়াহুড়া করতেছো কি জন্য?
অসুবিধা নেই স্যার, আরো 5 মিনিট সময় দেন স্যার।
5 মিনিট সময় দরকার, আমরা তো রেডি, বাট 3:38 শেষ করে 2:38 শেষ করে 3টার সময় শুরু করতে হয়। ওটা 2টা থেকে 3টা গ্যাপ দিলে নামাজ করে সবাই বসতে পারতো আর কি।
সায়েন্টিফিক সেক্রেটারি কন্ট্রোল করতে পারলো না।
পার্টিসিপেন্ট কত?
দেখি স্যার
59
32 স্যার, 32
33 হয়ে গেছে স্যার।
হ্যাঁ
স্যার 5 মিনিট ওয়েট করি স্যার।
করো।
কিন্তু মাঠ কই? মাঠ দেখা যাচ্ছে না কেন স্যার?
মাঠে বসি নেই তো,
ধানমন্ডি মাঠ।
মাঠে বসি নেই তো।
জয়েন করলাম, আরে জয়েন করলাম। খুশি আঙ্কেল, হ্যাঁ সালাম দাও একটা।
मामूली कम गया रे मेरी बात करी ये आपसे अलग आती नहीं
প্রেসিডেন্ট স্যার কি অফিসে নাকি? আপনি অফিসে?
بديع السماوات والأرض ولا يعوده حفظهما وهو العلي العظيم بسم الله الرحمن الرحيم قل هو الله أحد الله الصمد لم يلد ولم يولد.
স্যার শুরু করবেন? 50 জন হয়েছে পার্টিসিপেন্ট।
আমার তো শুরু করতে অসুবিধা নেই, সুদীপ কিছু বলবে না?
সুদীপ,
হ্যাঁ স্যার।
হ্যাঁ তুমি স্যারকে ইন্ট্রোডিউস করে দাও। সুদীপ,
হ্যাঁ আমি আছি, শুরু করব।
হ্যাঁ চেয়ারম্যান স্যারকে ইন্ট্রোডিউস করো, করে তারপরে শুরু হোক। হ্যাঁ
Respected members and dear residents, welcome to all of you our today's post-lunch session. And you all know that Professor Dr. A.K.M. Khurshidul Alam, Professor and Chairman Department of Urology, BSMMU, will be the moderator of this session. And this session topic is female urology. I don't want to waste time. I am going to directly to the moderator of the session, Dr. A.K.M. Khurshidul Alam. Sir.
Thank you, Dr. Sudeep, Scientific Secretary of Bangladesh Association of Urological Surgeons. Welcome you all to this after lunch session on female urology, which is a specialty of urology that focuses on the diagnosis and treatment of urological conditions that commonly affect women. These conditions are due to the urinary special unique anatomy of the female urinary tract and reproductive system. In this session, there are 4 lectures on midurethral sling, current controversies. Second lecture is the pelvic floor anatomy, treatment of pelvic floor dysfunction. And then third lecture is evaluation and management of pelvic organ prolapse. And last one is voiding dysfunction. This lecture is delivered by Dr. Priyanka Gupta, MD, Assistant Professor of Urology. He is a urological surgeon, specialist in the diagnosis and management of voiding dysfunction and pelvic floor disorders. She obtained her medical degree from the Mayo Clinic College of Medicine in 2009 and then completed her residency in general surgery and urology in 2010 and 14 in the University of Minnesota. She then completed a fellowship in female pelvic medicine and reconstructive surgery at the UniHealth in Royal Oak, Michigan. In 2016, during her fellowship, she gained additional experience in the surgical management of pelvic organ prolapse, urinary incontinence, and the use of neuromodulation and robotic technology. Dr. Gupta's clinical practice include both the surgical and non-surgical management of pelvic organ prolapse, especially robotic sacropulpopexy and native tissue repair. Also incontinence, pelvic pain, voiding dysfunction, and pelvic floor disorder. Dr. Gupta's research interests include outcome of pelvic organ prolapse treatment, and she's also interested in the international medicine and the use of simulation technology for improving surgical education in the developing world like Bangladesh. She is actively associated with American Urology Association, Society of Urodynamics and Female Urology, and Society International de Urology. So I now request the BAUS staff to see the video of first presentation. Thank you.
Hello, my name is Priyanka Gupta, and I'm an assistant professor of urology at University of Michigan in Ann Arbor, Michigan. It's my pleasure to get to present to you 4 lectures today on female urology. I'm sorry I can't be there in person to do this, but look forward to meeting someday. So we'll start with our first lecture today. It's entitled Midurethral Slings, Current Controversies. So why do we think about midurethral slings? Midurethral slings were designed to treat simple stress incontinence, and the defect that they were designed to correct is urethral hypermobility. The concept of a midurethral sling is for it to be tension-free and to provide compression during physical exertion. This is different from fascial slings, which we won't be talking about during this lecture. The goal of the tension-free midurethral sling is to minimize
No audio.
শুভ শোনা যাচ্ছে না? হ্যালো, শোনা যাচ্ছে না? অডিও নাই?
স্যার দিচ্ছি স্যার।
Okay. This is something that you want to examine your patients for when you ask them to cough, sneeze, or laugh. If hypermobility exists, the urethra will move. The midurethral sling is designed to correct this defect that we see here. So the objectives of this talk are going to be to focus on retropubic and transobturator slings and the differences between the two. We also will talk about newer single incision slings and then talk specifically about mesh complications. So the retropubic sling was the first mesh sling that was designed and introduced. It has a similar idea to the traditional autologous fascial sling, except the benefits are that there's less dissection with a mesh sling, but it does introduce a few interesting concepts. The blind pass, as you pass the trocars, either from above or below to above. And you can do this in top-down or bottom-up fashions. Some of the complications introduced by retropubic sling include bladder and bowel injury when you pass the trocars. So these are 2 schematics. There's 2 different ways you can pass a retropubic sling. This is a spark sling that's done from top to bottom. And you can see here the trocar being introduced just above the pubic bone and then being passed into the vaginal space. The other method in which a retropubic sling can be done is to pass it from bottom up. And here you can see the introduction of the trocar from the vaginal incision and being delivered just above the pubic bone with the needle exiting through a suprapubic incision. So which direction is better? I think people always ask, should you go bottom up or top down? So this is an interesting study, the Cochrane meta-analysis of 5 trials. This had 1-year follow-up and basically compared the 2 methods. And really there was very little difference seen between the 2. So looking at subjective cure rates, you see 85% versus 77%, and objective cure rates were almost the same, 92% versus 87%. There's really no statistically significant difference between the 2. We also look at adverse events, and you can see here that there's really very few differences between the 2. However, interestingly, bottom to top, there were less bladder perforations and less vaginal erosions of mesh and less voiding dysfunction. But again, these were not statistically significant. So the second method of passing of a midurethral sling is a transobturator sling. The difference in a transobturator sling compared to retropubic is that it follows a lateral vector. It goes through the obturator fossa and exits through the adductor muscles. The benefits of the transobturator sling and the reason it was introduced is it avoids the blind pass through the suprapubic incision. And again, there's two methods to this sling. You can pass it inside out or outside in. The complications that were introduced with the transobturator sling included complications of thigh pain as you're now going through the adductor muscles, and palpable mesh, which can sometimes be felt due to the lateral vector of the sling. So here's again some schematics. This is showing going from inside out, so passing the trocar through the vaginal incision and exiting through the adductor complex here, or it can be done outside in, where the trocar is introduced here through the adductor muscles and then brought out through the vaginal incision. And here the person is using a guide to help deliver the trocar into the vaginal incision. So again, which direction is better? So looking at the same meta-analysis, they looked at inside out and outside in and found that there was really no difference between subjective and objective cure rates. Again, when we looked at adverse events, there was no statistically significant difference between the two methods of passing the sling. But going from lateral to medial, there was more vaginal perforation, which can make sense as you're delivering the trocar into the vaginal incision. And then there was more voiding dysfunction in medial to lateral passage of the sling. So one of the questions that and compared retropubic and transobturator slings. When we look at the 2-year data, the objective and subjective success rates are similar. And when we look at 5-year data, we see, again, the same similarity between success rates. And both types of slings have high patient satisfaction rates. In a Cochrane review from 2015, when they looked at subjective outcomes between retropubic and transobturator slings, you can see that outcomes are fairly similar and remain so as we move from short-term to long-term. One point to look at both of these is you see that the subjective improvement rates start to decline some as we go into the long-term phase at 5 years. And part of that is due to the fact that patients may develop other de novo urinary incontinence symptoms, including urgency, frequency, and overactive bladder symptoms, which can cause their perception of improvement from slings to decrease. When we talk about long-term outcomes for slings, probably the best data we have is in the retropubic slings, as they've been around the longest. In this study, looking at 10-year outcomes of patients, 483 women with a median follow-up of 129 months. Again, we see great objective cure rates, about 90%, and subjective cure a little bit lower at 76%. Overall, patients are very satisfied. The longest study that we have is 17-year data looking at retropubic slings, and here some of the visits were conducted via telephone, and we see 90% cure rates. Single incision slings are another type of sling that has been introduced more recently and has really come back into vogue. It follows the same vector as a transobturator sling, but the benefits are that there's less mesh as the sling doesn't come all the way out through the obturator membrane, and thereby avoiding some of the complications of adductor muscle pain. Historically, when single incision slings were introduced, they had lower success rates, and a lot of that was due to the TVT secure. Some of the newer studies have excluded the TVT secure, which was taken off the market. And when we now look at the newer data regarding single incision slings, there's really no significant difference in objective or subjective results. However, our follow-up time is still shorter as these are newer slings that have been introduced. Some of the new single incision slings include these, the Adjust and the Alta sling. But the principle behind all of these slings is that there's less mesh and they have an anchor that basically goes into the obturator membrane so that you don't have to exit out through the adductor muscle and introduce mesh through that concept, through that muscle complex. There's an adjustable mechanism for tensioning in these slings. The Alta sling has had good 2-year results so far, 90% of patients improved, and the Adjust sling has also had comparable improvement. There have been several new studies in the last 4 to 5 years comparing the single incision sling to the traditional full-length transobturator sling, and they all show similar results at 1 to 2 years of follow-up. So I think as slings continue to evolve and we have more long-term data with single incision slings, they appear to be very promising and may remove some of the complications associated with a full-length mesh sling. So let's talk a little bit about safety. So slings have received a little bit of a bad rap due to press regarding vaginal mesh, and the Society of Female Urology and the American Urogynecology Society put out a position statement in 2016 declaring that mesh is safe and effective as a surgical implant. And I think it's important to realize that mesh urethral slings are probably one of the most extensively studied anti-incontinence procedures. There are more than 2,000 publications looking at outcomes, efficacy, and safety of mesh mid-urethral slings. We still consider these to be the standard of care for surgical treatment of stress incontinence, and they really are sort of the best first operation if done correctly. The FDA has also stated that slings are safe and effective in the treatment of stress incontinence. I put this conclusion here, but I think it's just a nice statement to reiterate why mid-urethral slings are important and why they've evolved over the last 50 years. If we think about all of the complications associated with fascial slings, the tension-free mid-urethral sling has really removed a lot of those. It is a same-day operation that gives patients great quality of life. And so it really is something to consider as sort of the gold standard for simple stress incontinence. So I want to talk about complications because I think that's one of the things that's really important with mid-urethral slings. So we're going to look at what the classification system is for complications, and then talk a little bit about mesh exposure and extrusion and mesh perforation. So the IUGA classification system categorizes complications into local complications, complications to adjacent organs, and systemic complications. Erosion is basically the state of being worn away by friction or pressure, and we don't really use this terminology anymore. So this is a classification system that's used to describe mesh complications. And I think the important terms to recognize are exposure versus extrusion. So exposure is when the mesh becomes displayed or revealed, so the vaginal epithelium separates and you're able to see the mesh exposed in the vagina, versus extrusion where the mesh kind of gradually comes out or starts to pass into another part of the body. So factors that are important to consider for mesh exposure. So there's certain patient factors such as the body habitus, if they have poor wound healing. So you can have patients that have a smoking history, have a history of radiation, have a history of diabetes. They may be more at risk for poor wound healing. And then there's the surgical technical factors when you place a mesh sling. So it's really important to make sure that the sling is laying flat and not folding or wrinkling, that it's not under undue tension, and to think about what material you're using as well. It's also important to be extremely diligent to check for vaginal wall injury to make sure that there's no mesh exposure. So mesh material, the initial mesh slings were non-type 1 mesh, and since we switched to a mid-type 1 mesh, which is a macroporous monofilament polypropylene mesh, the outcomes have been significantly better. And the reason for this is that the mesh has a large pore size, which promotes tissue ingrowth and incorporation compared to smaller pore sizes. So that's important for the mesh that you use for your sling. So looking at the two methods again, or the three methods, excuse me, retropubic, transobturator, and single incision slings, we can look at exposure. And you can see that exposure rates are slightly higher for retropubic slings and low for transobturator and single incision slings. Bladder injury rates are a little bit higher for retropubic slings as well. Urethral injury rates are low and bowel injury rates are low. So when we look at exposure data, these are a couple great studies that look at exposure rates with the different types of slings. And so exposure rates are characteristically low. I quote my patients 1 to 3%. In some meta-analyses, transobturator slings have been slightly higher, and that makes more sense with the lateral vector that you may have a vaginal perforation, and if that's not recognized at the time of surgery, that can lead to higher exposure rates with the transobturator slings. And that's definitely been my experience as well. And with the Thomas trial, the transobturator slings again had a slightly higher rate at the time of surgery due to vaginal perforation, and then follow-up exposure was a little bit higher. So again, as long as this is recognized at the time of surgery, this can be corrected. With adverse events, transobturator slings in general have less chance of vascular or visceral injury or bladder perforation, again, given the lateral vector that's being taken, but they introduce more groin pain, and then they have less avoiding dysfunction overall. The retropubic sling is thought to be a little bit tighter, and due to its vector may have an increased rate of voiding dysfunction, and also may have more suprapubic pain because, again, of the location that the trocars are being passed. But really, as much as we can see these slight differences in mesh exposure, there's been no difference in erosion rates. So there are a few, I think, key points to take in mind when you're performing a mesh sling to minimize mesh exposure. And I really think that the technical aspects are really important with this procedure. So one of the biggest things is to make sure that you have adequate vaginal wall thickness to cover the mesh. And in order to do that, hydrodissection is recommended. And then one of the things I'm extremely diligent about at the time of surgery is to palpate the vaginal wall and examine for any vaginal wall perforation that may have occurred with your trocars. I typically do this while the trocars are in place, and then do it again after I place a sling as well to make sure that I don't miss any vaginal wall perforations. If you do find one, then it's okay to remove the trocar, close the perforation, and repass the sling, and that can be done at the time of surgery. The Thomas trial showed that if you recognize and repair these perforations, that there won't be any complications. And at 2 years, they didn't note any significant increase in complications. Another important thing is to minimize hematomas, as formation of hematoma can cause vaginal wall separation and mesh exposure. And so this can be done by meticulous closure of your vaginal incision, and sometimes using a packing if there's more bleeding. Mesh exposure can present early or delayed. So early patients may notice increased vaginal spotting. They may actually feel the mesh if they feel their vaginal incision. But late, some of the common symptoms people will describe is discharge, pain, or partner discomfort and dyspareunia. And here's a picture of an exposed sling. So how do you manage mesh exposure? So if the patients are asymptomatic and not sexually active, and it's a small area of exposure, you can observe it or treat it with vaginal estrogen. However, if they are symptomatic, then you need to consider fixing it. One option is to try to reclose the vaginal incision, particularly if this occurs early, right after surgery. You can reclose the incision, ensure that you have adequate dissection and coverage. If this presents late, then it's important to remove some of the inflamed mucosa, potentially remove wrinkled or folded mesh if that's present, or mesh that's poorly incorporated. And then it's important to close the vaginal wall in a tension-free manner. So that means that you need to make sure that you mobilize the vaginal flaps enough in order to ensure that there's no tension so that the vaginal incision heals well. And this should be then closed with 3/0 absorbable suture. Next complication is mesh perforation or bladder injury. It's most common with retropubic slings given the top-down manner in which it's being passed behind the pubic bone. So in a meta-analysis in 2015, you can see the rates are higher with retropubic slings, 3% versus 0.2%. And the risk factors, again, are the blind passage of the trocars. And they found, interestingly, that there is a learning curve for retropubic slings, and they estimated that to be about 50 cases. And I have found that there is a slightly higher rate with new learners. And other risk factors include prior surgery, diabetes, and then interestingly, with a higher BMI, there's a decreased rate of bladder injury. So there are a few steps you can take at the time of surgery to try to prevent this from happening. One is to ensure that you have a completely empty bladder. With the retropubic sling, I do typically hydrodissect over the suprapubic area right behind the pubic bone in the retropubic space. I inject 20 milliliters of saline through a spinal needle. And then you can distract the bladder to the opposite side using either a cystoscope or a catheter guide through your Foley catheter. It is then important to make sure that you're passing the trocar directly behind the bone and feel it right on your fingertip as soon as possible. You should then perform cystoscopy and ensure that there's not been a trocar injury. I typically recommend using a 70-degree lens to have a good examination of the anterior bladder wall and to make sure that the bladder is full in order to not miss any perforations. If you do find a perforation, then you should remove the trocar and replace it. If that's done and recognized at the time of surgery, there are no long-term sequelae from a mesh perforation. And typically, if that happens, I'll keep the Foley for a few days just to be conservative. Some people have described not leaving a Foley catheter if there's a small perforation, and there have been no long-term consequences from that. If you don't recognize a bladder injury, it may present at a later time, and these are some of the symptoms that patients can present with. Irritated voiding symptoms, recurrent urinary tract infections. You can have formation of bladder stone, as seen here on the mesh material, and hematuria. If this happens, how do you fix it? So there are a few different ways you can try to remove the mesh. One is through an endoscopic technique. If it's a very small area of mesh perforation, people have successfully been able to remove it using endoscopic shears, either a transurethral resection or laser resection. My experience has been, however, that if there is a larger piece of mesh, this doesn't work well as the mesh continues to expose itself, and sometimes the best option is to actually try to remove the entire piece of mesh. If the exposure is located below the trigone, then you can approach it vaginally. If it is located above the trigone or through the trigone, then you may need to go abdominally. Sometimes you may require a combined vaginal and abdominal approach to remove the mesh. You may need to consider ureteral reimplantation as well, given the location. I've had some success with doing this robotically as well if you're going abdominally, because with the robotic approach, you can minimize morbidity from a large incision. So below the trigone, I typically will go vaginally and use an inverted U-shaped incision. And then it's really important to follow the entire piece of mesh into the bladder. And sometimes this is going to require a cystotomy, which will then need to be repaired from below. Depending on the coverage that you have, you may want to consider using something like a Marsh's flap for coverage. Urethral injury is very infrequent with mid-urethral slings. You can see the rates here, 0.2 to 0.3%. Some of the risk factors can be previous surgery, poor vascularity, so patients that have been radiated or have a history of smoking, and then estrogen deficiency can also play a role. I think the most important factor to consider with urethral injury is really technical factors at the time of surgery. So if the sling has been overtensioned, that can cause erosion over time. If the depth of dissection is not correct, that is probably the most significant factor. So one tip that I would recommend is that when you've completed your periurethral dissection, I always feel the amount of tissue over the catheter to ensure it's not too thin. If it is too thin, that's the time to correct it at the time of surgery. And you can raise an additional periurethral flap and cover the urethra prior to placing the sling to prevent this from happening. The other problem can be if you place the sling through part of the urethral wall, then that may erode over time. Some people have also described a technique of dilating the urethra by placing dilators to pull down on the urethra to help with the tensioning of the sling. That can cause significant problems. I would not recommend doing that and can potentially lead to urethral injury as well. The ways to determine this are to try to use a short beak cystoscope. If you're concerned about a urethral injury, this can help you better examine the urethra. If a urethral injury has occurred at the time of surgery, then you should abort the sling, fix the defect, and come back another day. If it presents in a delayed manner, these are some of the symptoms patients may describe: de novo urgency, obstructive voiding, recurrent infections, hematuria, and incontinence. So again, you can try to manage this endoscopically if it's a small area of injury. However, again, in my experience, most of the time this is difficult as you're not able to remove all of the mesh and it may end up presenting later. Therefore, a transvaginal excision is really the best option. Again, consider a U-shaped flap, find the area of the erosion, and then follow the sling and remove as much as you can vaginally. You may want to consider a Marsh's flap when you repair the urethrotomy. And for some patients, it may be worth considering a fascial sling if they have significant stress incontinence, because after the surgery, that may be persistent, and that can help improve their outcomes. Typically, after a urethral injury, I'll leave a Foley catheter for 7 to 14 days. You could consider avoiding cystourethrogram to make sure that your incision had healed. In general, I would say this is difficult to perform on women given the short length of the urethra, and I usually do not perform avoiding cystourethrogram. Instead, I monitor the patients for leakage after surgery. And I think the biggest counseling part to remind patients is the risk of stress incontinence after removal of their sling. Bowel injury is another complication. This is very rare and typically is only seen with retropubic slings. The most common patients that you may see this in are people who have a history of significant abdominal surgeries. And typically, patients may present with abdominal pain, peritonitis, symptoms of nausea and vomiting, and you may even see bowel contents through the trocar sites. And these delayed presentation may be, within 7 to 10 days, but this is obviously a significant complication. Ways that you can prevent this are to consider patients that have had prior abdominal and pelvic surgeries. You may want to get preoperative imaging to examine whether the retropubic space is safe and clean for trocar passage. And if you're concerned about a patient, then I would suggest considering another approach, such as a transobturator sling or single incision sling in these patients. As we talked about, you want to make sure you hydrodissect if you are going to do a retropubic sling, and make sure you hug the bone with the trocar. Typically, if this does occur, you would consider excising and repairing the area of bowel injury and lysis of adhesions. So other things to think about: sexual function with midurethral slings. So in general, sexual function improves after the surgery. Oftentimes that's been attributed to decrease in coital incontinence, which makes patients more confident. And in general, with midurethral slings, there's not been an increase in dyspareunia. It is extremely rare that I've had to remove a sling for dyspareunia. Typically, we see this more with vaginal mesh used for pelvic organ prolapse. The TOMAS data also showed that patients had improved sexual function with decreased dyspareunia, coital incontinence, and fear of coital incontinence. And overall, they had improvement in their sexual function on questionnaires. So pelvic pain is another sort of big question that's always asked with mesh midurethral slings. And the etiology is thought to be due to too much tension from either the plicating sutures or the mesh arms of the sling. If you're concerned about pelvic pain due to a midurethral sling, I examine the patients very carefully to see if their pain is reproduced by palpating over the area of previous scar. If that does reproduce their pain, then you may want to consider incising the scar. However, in general, most of these patients really benefit from pelvic floor physical therapy and may benefit from trigger point injections. Oftentimes what I find is if I examine their pelvic floor and push on the areas of their pelvic floor musculature, oftentimes that's where they're feeling the pain and not over the area of the sling. If that's the case, then removing the sling is not going to improve their pain. However, if you do identify that they are tender over the area of the sling, then you can consider mesh removal. And data suggests that in those patients, 50 to 60% do have some improvement in their pain. So in conclusion, slings are the gold standard for stress incontinence. I always emphasize with residents that you should choose a sling that is best in your hands. If you feel most comfortable with retropubic slings, do that. If most comfortable with transobturator, you should do that. Really, the outcomes are similar between the two types, and as of now, single incision slings also appear to have similar outcomes. Mesh complications do occur, and it is really important to counsel patients appropriately before surgery. It's also important to manage their expectations. And I would put a plug in again for pelvic pain. If your patients after a sling do present with this, really consider pelvic floor physical therapy prior to rushing to incise a sling. Thank you. Okay, our next lecture is going to be on the pelvic floor anatomy and dysfunction. The objectives of this talk are to look at the bony pelvis, the landmarks, and the ligaments. We'll identify the female pelvic floor anatomy and why this is important for evaluating pelvic floor dysfunction. And then we'll talk about management strategies for this condition. So here's a nice diagram looking at the bony pelvis. And some of the important structures to familiarize yourself again with are the location of the obturator foramen, which is important for midurethral slings, as we just talked about in the last lecture. Also to identify where the sacrospinous ligament is, which is right here. You can see it going from the ischial spine to the sacrum. The sacrotuberous ligament, which helps outline this area of interest. And then the greater sciatic foramen and the lesser sciatic foramen. Here's another view of the pelvis, and this shows really how the pelvis tilts in a woman when she's standing. And this is important when you're thinking about the angles for pelvic organ prolapse as well as the angles for passing your sling. So there's this tilt that happens when a woman stands up, and then when they're lying down, that tilt changes. And so it's important to think about the axis and angles. And if you're thinking about fixing pelvic organ prolapse, you want to think about how you're suspending the vagina and consider how it's going to be lifted towards the sacrum. So again, why does this matter? So we need to know where the ligaments in the pelvis are, particularly when we do pelvic organ prolapse repair, and we'll be talking about that in a different lecture. The bony landmarks are important so that you can identify the muscle groups in the pelvis that you may be treating or identifying for pelvic floor dysfunction. And then the sacral anatomy is important if you perform neuromodulation, as you need to be able to identify the S3 foramen. And then this is also important as it can be altered in congenital disorders, which you can, again, something you may need to examine patients for if you're concerned about neurogenic bladder. So here's another diagram of the pelvis, and here's the sacrospinous ligament, the greater sciatic foramen, and the lesser sciatic foramen. So again, something important when we do prolapse repairs. So in this talk, one of the things we're going to really focus on with the anatomy is the anatomy of the pelvic floor musculature. So the coccygeus muscle, the iliococcygeus muscle, and the pivococcygeus muscle make up the levator plate, levator ani musculature of the pelvic floor. And I always describe to patients how this is a bowl of muscles that's really supporting all of their organs in the pelvis, including the vagina, the bladder, and the rectum. And that description can be really important when you're counseling patients about how these muscles play a role in bladder dysfunction, bowel dysfunction, and sexual dysfunction. The other thing that's important to recognize is how these muscles fuse at the midline and attach to the levator plate here. And then they rise and attach up into the pelvis as well and support the upper vagina and cervix. The other muscles that we'll talk about as well are the obturator internus muscle and externus muscle. The urogenital triangle represents some of the additional muscles that are smaller that we may see, such as the bulbospongiosus muscle and the ischiocavernosus muscle, which can be important for sexual function, and the compressor urethra and the sphincter urethra vaginalis, which again are important when thinking about incontinence mechanisms. Here's another view of the pelvic floor muscles, and what I like to emphasize in this picture is the piriformis muscle, which is also really important in pelvic pain. You can see that patients have this kind of extend along the lower back, and a lot of patients that complain of pelvic floor dysfunction will complain of pain that extends up into the lower abdomen and lower back, and you'll often find that the piriformis muscle is involved as well. So here's sort of a common clinical scenario. I see these patients all the time. A young woman who comes in with 1 year of increasing urgency, frequency, and bladder pain. She says it hurts her all the time. She's constantly in the bathroom. So what are the questions that are important to ask about in the patient's history? So it's really have incontinence? When do they have pain? Does their pain occur when the bladder fills? Is it better when it empties? Is it there all the time? Is it associated with intercourse? What are kind of the factors? The other thing that is part of this history is what are the patients drinking? What are they eating? Sometimes patients come in with this history and you find out that they're drinking 12 sodas a day, and that can be sort of a big culprit. So taking the time to get a good urologic history is important. The next important part of their history is their bowel symptoms. So a lot of patients with pelvic floor dysfunction are often either constipated or have diarrhea or maybe a component of IBS. And so understanding what their bowels are like, are they straining? Do they take laxatives? Are they doing anything to manage this? Then I ask about gynecologic history, parity, have they had previous pelvic surgeries? And then a very important question is, do they have dyspareunia, and does that occur? Has that been occurring prior to this condition? Is that still happening? And when does that occur? And then another kind of important part that I would emphasize that we don't always think about as urologists is their mental health. Oftentimes, particularly in this young population of patients, you'll find out they have significant stressors with work, anxiety, depression. They may have taken on a new job, maybe they're studying for an exam, and some of those stressors are precipitating their urologic symptoms. So next component of evaluating this kind of patient is a physical exam. So I do a Q-tip test when patients say that their vagina hurts. I do a Q-tip test of the vestibule at 3, 6, 9, and 12 to look for pain right at the opening of the vagina, because that pain can be treated differently than deep pain. So this can help point to vestibulodynia being part of the issue. Then I do a pelvic floor muscle exam, and this is really important. So first I look externally if they're having any pain along the edges of the anterior superior iliac spine or along the pubic symphysis. And then I look at the internal muscle groups. So this is kind of a nice diagram, and I look sort of at each quadrant and point and basically feel over the muscle areas. So on the right side of the patient, I'm looking at the right obturator internus and externus, and then the levator ani as I bring my finger down, and then on the left side, similar. So this is a nice diagram kind of showing how you do this exam. And what I do is I feel in each quadrant, and I press with my finger along the muscles, and I ask the patients, are you feeling pain when I push on these muscles? And does this reproduce your pain? And does it reproduce your bladder symptoms that you feel? So again, here I'm feeling the obturator internus and the levator ani. The other thing that can be helpful is to do some dynamic maneuvers. So when you palpate the levator complex, I will also ask the patients if they can isolate and contract those muscles. That's important because if patients have significant pelvic floor dysfunction, they often cannot coordinate those muscles correctly, and that might be someone that you would point towards physical therapy. This is also important when patients say that they know how to do Kegel exercises. Sometimes when you ask them to actually contract their muscles, they lift their entire body up off the table, and so you know that they're really not contracting their pelvic floor correctly, and that's something that you can help them with. So this was some research done through the MAP network that was looking at how can you do a reproducible screening exam. And really, I think that this is important in terms of doing a exam that is standardized and examining the patients in the same way to look at the muscles. And that's something that you can do by examining each quadrant systematically. So pelvic floor dysfunction, it really includes several disorders. Patients can have incontinence, urinary dysfunction, they may have prolapse, they may have fecal incontinence and defecatory issues. Sometimes you see this specifically related to peri and postpartum issues. And then within hypertonic pelvic floor disorders, patients can have pain, dyspareunia, they can have deep vaginismus or vulvodynia. So these are all kind of included in sort of the wide spectrum of pelvic floor dysfunction. So when we start to talk about treatment, there are a few different types of options that we can consider. I'd say the first thing to consider is whether there are any significant urologic disorders that we can evaluate for and treat. So urinary tract infection or other infections being a simple one, overactive bladder, screening them for kidney stones or bladder stones, and then also, of course, always ruling out urologic cancers as a source. I would say that physical therapy is really a gold standard, and when you think about any of these patients that present with pelvic floor dysfunction, consider whether there's a role for physical therapy. Then you can think about medications, and when we talk specifically about pelvic floor dysfunction, these are some medications that we'll go into a little bit more detail. And then I would encourage you to think about some alternative treatments like pelvic floor injections and neuromodulation, which we'll talk briefly about. So pelvic floor physical therapy, what does that involved? And patients ask me this all the time. So I think it's important to describe to patients that they are going to have manual manipulation that's done, both externally and vaginally, so that your patients are prepared and they're not afraid when they show up at the physical therapist. Depending on the physical therapist, they may use some combinations of electrical stimulation, TENS units. They may do biofeedback with the patients. And then depending on the dysfunction that the patient has, they may use cones or dilators. And particularly in patients that have pain, I will often ask them, did your physical therapist use dilators? Did they help you work on those muscles and learn how to relax them? And sometimes I'll find that they went to see a physical therapist who just taught them how to do Kegel exercises, which really that's the antithesis of what someone who has a hypertonic disorder needs. And so it's important to question your patients if they're not responding to physical therapy about what types of maneuvers were being done, to ensure that they're actually getting optimal therapy. So this is a review looking at how effective physical therapy is for certain conditions. So for stress incontinence, women who underwent physical therapy were 8 times more likely to report cure and 6 times more likely to have improvement. For urge incontinence, pelvic floor physical therapy was also effective, with patients having fewer leakage episodes during the day. And then with myofascial pain, again, you can see significant improvement in patients. So this is kind of a nice summary of showing the evidence for using physical therapy for hypotonic disorders and hypertonic disorders. And you can see that it's basically useful for most of these conditions. The ones where it's maybe the least effective are pelvic organ prolapse, and we'll talk about that in our prolapse lecture, and for patients who really need surgery for their stress incontinence. So next, let's talk a little bit about medications. So there are several medications that you can consider using for pelvic pain and pelvic floor dysfunction. So vaginal Valium is something that anecdotally I can tell you I've had success with. When you look at some of the trials, the success for vaginal Valium is a little bit less, and there may be some placebo effect. In this particular study, they didn't notice any significant difference with using vaginal Valium. In some patients, I've had extreme success with using this. I think one of the key factors with using vaginal Valium is making sure that you counsel patients that there can be some systemic absorption of the medication. And in general, what I find too is I often will use this in conjunction with physical therapy. So you can see here that they said that in this study they didn't do any complementary treatment modalities. What I found is it's most effective if the patients are using it, for example, prior to their physical therapy appointment, because it allows them to relax, and then it allows the therapist to be able to work deeper in the pelvic floor muscles. Another medication that's often used for pelvic pain is amitriptyline. There's been some good evidence in randomized studies that it can be very effective for patients that have interstitial cystitis or bladder pain syndrome. And so I think this is a medication to consider when patients have bladder pain and urgency. I think it is less effective for patients that have just pelvic floor dysfunction. So again, if their symptoms seem to be more bladder centric, then amitriptyline may be something to consider. Gabapentin is another medication that, as we know, is used for a variety of chronic pain conditions. It can really be effective for some patients that have vulvodynia. This study was a randomized control study that looked at patients that had vulvodynia and were assigned to the use of gabapentin. And the patients reported improved sexual function and improvement in their pelvic muscle pain severity. Typically, when I prescribe the gabapentin, I will start with 100 milligrams 3 times a day, and then I will titrate it up depending on how the patients tolerate the medication up to 300 milligrams 3 times a day. I will caution you that if patients are on a lot of other medications, that sometimes at that point I will defer the prescription of gabapentin to the patient's pain management specialist if they're on other psychotropic or pain medications, just due to my concern for interactions. However, if this is sort of a more isolated condition, then gabapentin might be something you may want to consider as a treatment option. So trigger point injections are something that I would encourage you to learn how to do and to think about when it comes to pelvic floor dysfunction. So again, the focus of using this treatment modality is on patients that have hypertonic pelvic floors, high tone pelvic floor dysfunction. So again, as a review, these are patients that when you examine them, they have significant pain along the levator complex with palpation. Sometimes when you examine them, they have tight bands that you can palpate with your finger, or they may not even tolerate a pelvic floor exam. So the way that I do trigger point injections is I use a curved nasal trumpet, and so this is actually an ENT instrument that's used for irrigation, and I use a 7-inch, excuse me, these slides are advancing. This is a 7-inch spinal needle that goes through the trumpet cannula, and so you can pass that through the cannula, and then by using this curved instrument, what it does is it helps protect your finger when you're deep inside the vagina, allows you to kind of feel and get right behind the pubic bone without injuring yourself, and then be able to advance the needle into the musculature. So I typically use a standard protocol when I do transvaginal injections, and I inject at 1, 3, 5, 7, 9, and 11 o'clock. And I usually do 2 sets of injections. So this is a distal, and I'll show you the positions of these, but distal immediately behind the bone, and then I do a proximal injection, which is at the level of the ischial spine. So here on this diagram on the side, you can see what I would call my proximal and distal injections. So my distal injections are here, the yellow and the black and the orange, and they're right behind the pubic bone. And then my proximal injections are here at the level of the ischial spine. So this is a AP view of the injections, and then this is a sagittal view of the injections. So again, you can see that these are the injections that are being done right behind the bone. So the blue and yellow, and I'm going to go back and forth here, are at 1 o'clock right behind the bone, and those are addressing the obturator internus and externus. And then the 3 o'clock injections are here. So this is a distal again, right behind the bone, and then the proximal. And these are addressing the levator complex, the iliococcygeus, the pubococcygeus, and the puborectalis muscles. And then the 5 o'clock injection is deeper. So this is at the level of the ischial spine here, the screen injection. And then the orange one is right inside the opening. So we did a cadaver study looking at where these injections went and looked at what muscle complexes they went into. And what we found with this 5 o'clock injection is that you're actually getting into the ishiorectal space where there's very little musculature, but the 5 o'clock proximal injection really injects at the level of the pudendal nerve and allows you to do a pudendal nerve block. So what kind of medications can you use for these trigger point injections? So I typically use 25 cc's of 0.5% either bupivacaine, ropivacaine, or marcaine, depending on what I have available. And I mix this with 1 cc of triamcinolone, 40 milligrams of triamcinolone. So I have a total of 26 cc's. And I'm doing 12 injections. I inject 2 cc's at each location. And at the 5 and 7 o'clock position, so again, as a reminder, at that position, that's where we're injecting at the level of the ischial spine and the pudendal nerve. At the pudendal nerve, I do 3 cc's to do a pudendal nerve block. And so that's at the 5 and 7 o'clock positions. So for an injection protocol, I typically will do injections every 6 to 8 weeks. I typically don't like to space them any closer together, as I feel like the steroids in the muscle could potentially be harmful over time. These injections can be done in clinic or the OR, and what I've found is when you have patients that come in sort of severe distress with really high tone pelvic floor, oftentimes doing an injection in the clinic can really salvage these patients and provide them with almost immediate relief. The injections are really most effective if you pair them with physical therapies. So sometimes I start patients on injections if they can barely tolerate a physical exam, because otherwise they may not even tolerate their physical therapy. Other times I work closely with my physical therapist and they'll communicate and say, this patient is really tight, I'm having trouble being able to work their muscles. They might benefit from a series of injections, and in those patients we'll then start injections so that they can progress further with their physical therapy. One of the questions that I always get asked by patients is, how long do these injections last? And I would tell you, as with any pain treatment, the outcomes really vary between patients. So some patients may have effects that might just last for a few hours. And I have some patients where it can last several weeks to even months, and they return for injections maybe once every 6 months. So there really is a wide variability between response to these treatments. This is a paper that I did with my cohort at Beaumont Urology, and we did a retrospective review of women who were receiving transvaginal trigger point injections. The mean number of injections that patients received in a session was 5 injections. And what we found when we analyzed the patients is that the type of anesthetic we used didn't really make a difference. What did make a difference was how much we injected. So in general, an injection of at least 19 cc's or more was important. So doing that full template of injections tends to have better success rates. And the adverse effects were fairly minimal, but the main ones that we did see were leg numbness. And typically I see this probably in about 5% of my patients that may present with some leg numbness immediately after injection. Due to that, I ask them to bring a driver if I do it in clinic. And usually that leg numbness wears off within 24 to 48 hours. Some patients experience some immediate dizziness and nausea with a bit of a vasovagal response. And there is some vaginal bleeding, and some patients reporting headache. You can see here in these scores, when you look at their pain scores between pre-trigger point injection and post-trigger point injection, you can see there's a significant improvement in pain scores. And you can see this across visits when we go from their first visit to their 4th visit, that their pain scores significantly decreased. So again, this is where pelvic floor injections can be really effective. So in patients that respond well to pelvic floor injections, another consideration might be to use pelvic floor Botox. So pelvic floor Botox can also be used for myofascial pain, and I typically reserve this for patients who had a good response to traditional trigger point injections, but the response wore off very quickly. And those patients using Botox may allow them to have a longer time of response. So in this paper, they looked at 31 patients who underwent Botox injections, and they injected between 100 to 300 units. And you can see here, 80% of patients reported improvement in pain, and about half the patients underwent a second injection. Median time to injection was 4 months. In general, I tend to inject 200 units divided into 24 cc's in the 12 sites that we were describing earlier for the injection technique. And I have some patients that receive injections, really I would quote between 6 to 12 months. I have some patients that are every 3 months, and I have some patients that are 6 to 12 months for their duration of effectiveness. The adverse effects in this paper, there were 3 patients that had urinary retention, 2 with fecal incontinence, and 3 with constipation, all which resolved. I, in my experience, have not had any of these complications yet, but I'm sure with enough injections, those are things that we may see. So as I described, the injection method is the same. You can use the same template, or you can inject specific or discomfort would be the use of neuromodulation. There have been some smaller studies that have shown that sacral or pudendal neuromodulation can benefit refractory pain patients. I think sacral neuromodulation can be really effective in patients that have bladder-centric symptoms, so patients that have significant urgency, frequency, and overactive bladder symptoms really tend to benefit from sacral neuromodulation, because those patients, if you can improve their overactive bladder symptoms, oftentimes you can improve their pain as well. Pudendal neuromodulation is an off-label usage of neuromodulation, and myself and Dr. Peters, as well as some other specialists in pelvic pain, have published extensively on this area and have found that in patients who have significant pudendal neuralgia, these patients can really benefit from placement of stim at their pudendal nerve. Typically, I choose these patients by patients that respond well to pudendal nerve blocks, then I may offer them a trial of neuromodulation. Again, just an important thing to realize, this is not, in the United States, this is not an FDA-approved treatment for pain. The manufacturers of the Medtronic device do not have approval for it. However, again, several studies in Europe and the United States have shown that this can be an effective treatment. So sort of in summary, I would urge you to think about pelvic floor dysfunction as a multimodal therapy that really requires a good behavioral assessment, and then consideration of usage of physical therapy, medications, and potentially other interventions like trigger point injections or neuromodulation that we can offer as urologists. Thank you.
হ্যাঁ সুমন, পরের টপিকস দিয়ে দাও। শুভ শুভ সুমন,
Okay, so our next lecture is going to be evaluation and management of pelvic organ prolapse. So in this lecture, we're going to talk a little bit about the background of pelvic organ prolapse, talk about how to evaluate patients, and then talk about the non-surgical and surgical management. So when I talk to patients about prolapse, I always explain to them that this is a hernia of the pelvic organs. And sometimes that can be a nice way for patients to understand exactly what's happening to them. And then I try to explain to them that there can be a hernia of any one of the three walls of the vagina, depending on where the defect may occur. So if it's the bladder, it could be a cystocele, it could be a vaginal wall prolapse, or it could be a rectocele. The literature estimates that 3 to 50% of women at some point in their life may experience some degree of pelvic organ prolapse, and that there's probably a higher percentage of prolapse on exam than what patients are actually symptomatic from. 40% of women older than age 50 may experience prolapse, and the lifetime risk of actually needing surgery for it is 7 to 11%. The levels of vaginal support were described in a study by Dr. Delancey that really looked at the different levels of vaginal support and where defects could be present. So level 1 prolapse is when you have prolapse at the top of the vagina, so either of the uterus or the vaginal vault or cuff. Level 2 prolapse is when you have prolapse of either just the anterior or posterior vaginal wall, resulting in a cystocele or rectocele. And then the third level of support that can contribute to prolapse is at the level of the vagina, vaginal opening, so the urethral support or defects in the perineal body. So that would be level 3 prolapse. So here's some pictures looking at what prolapse can look like. So here, this is a pretty significant uterine prolapse. You can see the cervix completely protruding, and along with it bringing part of the rectal wall and vaginal wall. This is a vaginal vault prolapse. So the uterus had already been removed, but here you can see the entire vault of the vagina is prolapsed. Here, it's a little bit hard to tell what may be prolapsing. It's likely the anterior vaginal wall and a cystocele, but this is how prolapse can present in so many different ways depending on the bulge. And here's another view of a different type of prolapse. And again, this might be more urethral than bladder and would require kind of more in-depth examination to determine this. So what are the goals of prolapse treatment? The goals are, first of all, to consider restoring the anatomy back to its anatomical position, to decrease the bother to the patient, and overall maximize their improvement and satisfaction. I always think of the most important thing to me is really improving their function, so their bowel, bladder, and overall sexual function and quality of life, and to choose an operation where I'm going to minimize the morbidity to the patient. So symptoms patients may present with, probably the most common symptom that patients describe is a feeling of bulge or feeling something kind of protruding from the vagina. Patients will describe seeing it or feeling it when they wipe themselves and feeling something that shouldn't be there. Sometimes they'll describe feeling a perineal pressure or something falling out of the vagina. I would say the hallmark of prolapse is that if the patient is not bothered, so even if they say, gosh, I see something or I feel something, if they are not bothered by their prolapse, then you really don't need to treat it. It's something that can be observed. I think the big problem is when patients have non-classic symptoms, so they have symptoms of overactive bladder, they feel like they're rushing to the bathroom or straining to go to the bathroom. Or another common one is they come in and say, well, I'm very constipated, so you must fix my rectocele. Or they have discomfort. That's when you have to start to question, is the prolapse a contributing factor to these symptoms or not? So here's an example of how we examine the prolapse. So I think the first question is, where is the patient's prolapse and how bad is it? And so that's where the POP-Q system had come about in terms of trying to understand and quantify prolapse. So in the POP-Q system, the AA point is the point that is 3 centimeters proximal, so behind the opening of the vagina, and it can range from -3 to +3. The BA point is the most dependent part of the vaginal wall, so that's just higher up, and it's the part that would come out the most when you ask the patients to strain. On the posterior wall, the AP point is again the point that is 3 centimeters proximal to the hymen, and the BP part is the most dependent portion of the wall here. So when we describe stages of prolapse, stage 0 is when there's no prolapse. Stage 1 is when the criteria for, there is some prolapse, but it is not more than 1 centimeter. It doesn't go past 1 centimeter above the level of the hymen. So basically it should be above -1. Stage 2 is when you have distal prolapse that is either past 1 centimeter, so it's either -1 or goes just past the opening of the vagina. Then stage 3 is when you start having a more significant prolapse that's below the vagina and 1 centimeter below the hymen. And then at stage 4, they have complete procedentia or vault eversion. So you see here these comments about rare, normal, real, and really I would say that, you know, stage 0 to 2, you would expect to be sort of normal variants on patients that have delivered children. People start to be symptomatic when they start to get to point 0 and +1, and the vagina is starting to hang out past the vaginal opening. And those are the patients where really surgical treatment or treatment of their prolapse can improve their symptoms and make a difference. So here's just another diagram of how to think about the stages of prolapse. So again, stage 0 is where you have no prolapse. and then ranging from 1, where it's still within the vaginal vault, stage 2, when you start to reach the opening of the vagina and maybe protrude just past it, stage 3 and 4, when the prolapse has started to come out past the vaginal opening. So here's another schematic of the POPQ, and you can see all the points of the POPQ. And so here's a vault eversion, and you can see where a vault eversion would be described as everything is coming out. So these are all pluses. And if it was normal and you had everything inside, then everything would be minus. So here's a cystocele. So you can see here the bladder is just coming out, but the uterus and rectocele are normal. So then you see plus values on the anterior wall, negative values on the posterior wall. Here's a rectocele, so the opposite, and you see plus values on the posterior wall, negative values on the anterior wall. So I would comment that the POPQ is very complicated and somewhat subjective. You can see that depending on how hard you ask the patients to strain, maybe if it's later in the day and they've been on their feet for longer, that you may see a more extensive prolapse than you may see earlier in the day. And so the POPQ can, one, be very subjective, but it also can be very complicated to assess each component of the vaginal wall. So I would say that sometimes this is a little bit more of an academic pursuit. But the reason for it is it does help us to write papers and all have common language with which to describe a prolapse. I would say from a more practical standpoint, the prolapse really, what matters is the patient symptomatic and is it past the vaginal opening to the point where you may want to correct it. And so here, describing it more describing it maybe verbally and saying, okay, the anterior vaginal wall is coming past the hymenal ring or it's coming past the vaginal opening might be a more clinically useful way to think about the prolapse. So here's a paper, is the severity of prolapse associated with the severity of symptoms? And I think this again goes back to our question about whether you need to treat the prolapse or not. And so in this study, 521 women were answered questionnaires about their prolapse and then answered questionnaires about incontinence and bowel symptoms. And the only symptom that was associated with the stage of prolapse was the feeling of bulge. Otherwise, all of the other symptoms of incontinence, bowel dysfunction were not associated with their anatomic stage of prolapse. So this emphasizes that POPQ tells you where something is in the vagina, where the prolapse is, but what it doesn't tell you is how it's contributing to symptoms and whether it needs to be treated. So really, I think the clinical relevance has to be, you have to really think about whether the prolapse is contributing to the symptoms or not. So a historical perspective, this is kind of a interesting picture to think about how far we've come, but prolapse has been around for a long time. And people used to describe all kinds of ways to get rid of it. There were descriptions in some of the historical textbooks about hanging women upside down to make it go away, scaring it away, trying to poke it in with a hot poker. So we've, thank God, evolved from this type of treatment for prolapse. So non-surgical treatment options. So there are, you can observe, as we talked about, probably the best thing is if they are asymptomatic, provide the patient's reassurance and counsel them it's okay to watch it. Weight loss can be helpful. Physical therapy can be helpful. And then some other non-surgical treatments that we'll briefly talk about are pessaries, and you can use topical estrogen if there's irritation of the skin. So this was a sort of landmark study, the POPPY trial, that looked at women that have pelvic organ prolapse and underwent physical therapy. And what they found was that in women who underwent pelvic floor physical therapy, the symptoms that they felt from prolapse, so the feeling of bulge or discomfort, went away, but there was no difference in the stage of prolapse. So what I counsel patients about with physical therapy is that it will make them feel more comfortable, but it will not make their prolapse go away. So if patients have kind of mild symptoms, this might be something to consider. The second option I mentioned to you all is pessaries. So there are a whole bunch of different kinds of pessaries. Probably the most common one that I use is the ring with support. So that's E here. And that's probably the most comfortable and easiest for patients to use. In patients that have severe vault prolapse, the Gellhorn here can be really helpful for helping to hold things up. So pessaries have been also around for a long time. Pessaries that have been described in the medical literature include things like pomegranate soaked in vinegar, tampons soaked in medicine, balls made of strips of linen, hammer brass and wax corks, but all with the idea of trying to hold the prolapse inside the vagina. So like I mentioned, these are the most common types of pessaries. The ring with support is probably the one that like I mentioned, I use the most because patients are able to take it in and out on their own at home. But it is less helpful for more severe prolapse. If patients have kind of stage 3, stage 4 severe prolapse, you may want to consider using a space-filling pessary. And these can be more difficult to insert, and with them you can't have coitus. Typically for these types of pessaries, patients need to have them removed and replaced in clinic. So for patients that do rings with support, if they do it at home, I usually advise them to wash it every few days or once a week. And I see them every 3 to 4 months to ensure that they're not developing any vaginal erosions or complications in the pessary. So the benefits of pessaries, they remove the bulge. It can improve post-void residuals if patients are retaining urine. It can help improve some of their overactive bladder symptoms. So sometimes it can be a good test to see if fixing their prolapse may improve their bladder symptoms. And it can correct stress incontinence. The risks of it is a hassle. Patients often complain of more vaginal discharge, having to sort of deal with the pessary and manage it. There can be development of vaginal erosions of the vaginal wall that can require a pessary holiday. Patients may not be able to have intercourse with the pessary, and sometimes patients just can't be fitted if their prolapse is really severe or if they have a very gaping vaginal introitus. Sometimes the pessary just falls out and they can't accommodate it. For some patients with significant vaginal atrophy, a pessary can also cause discomfort and they may not be able to use it. So let's talk now about surgical options. So there are 2 approaches to fixing prolapse. You can either do this vaginally or abdominally, and then abdominally you can consider an open repair or a laparoscopic repair. So for vaginal surgery, first we can talk about cystocele repairs. So a traditional sort of native tissue repair, here's a cystocele, involves making an incision on the vaginal epithelium and dissecting the epithelium away from the perivesical or pubocervical fascia, and then plicating that fascia and helping to support the cystocele, bladder neck, and urethra. And then you may need to consider whether you need additional support of the apex, which we'll talk about. So here's a nice schematic kind of showing again the periurethral fascia. So the vaginal wall has been incised and dissected, and then you have kind of the fascial layers here. So here's a operative picture. You can see the epithelium has been opened and dissected away. And then here that perivesical pubocervical fascia has been plicated to reduce the prolapse here. So some of the concerns about doing this type of native tissue repair is that the prolapse has occurred because the patient's tissue is weak to begin with. And so when you place weak tissue under tension, it may or may not heal. So in general, it's been thought to have poor anatomic outcomes compared to using something else. And this is the reason that people started to talk about whether we should augment our native tissue repairs with something like a graft. So should you use a graft? So reasons you might consider it are that you can bypass the weak tissue, it might be more durable in the long run, and it can be a reproducible technique. Also, when you plicate the perivesical fascia, you're narrowing the vagina some, so if you use a graft, you wouldn't be causing that narrowing. So this is a picture of using mesh in a prolapse repair, and you can see here how that lays across the anterior vaginal or against the pubocervical fascia against the bladder and helps to reduce the prolapse. So when people study anatomic success, so these are several studies compiled together in a systematic review, and you can see that the anatomic success of mesh was significantly higher compared to a native tissue repair. However, interestingly, when we examine the symptomatic success, you can see that the symptomatic success was actually the same between a native tissue repair and a mesh repair. So this begs the question about how do you define success in prolapse repair? And the definition of success has really changed to be based more on patient symptoms and quality of life, because that's really what's most important to the patient. Anatomically, we may examine the patients and say, there's been a slight recurrence of your prolapse, you're not a stage 0 anymore, now you're a stage 1. But if the patients are asymptomatic, then that's still a successful surgery. So in essence, like I just mentioned, success is absence of symptoms, and it's really correlates best with the patient perception. And so you have to weigh the risk and benefit of the approach that you're taking for the outcome you're trying to achieve. So reoperation rates between the two, and this is where these adverse events really come into play. Anterior repair is fairly low, mesh rates are a little bit higher. And complications are really low for native tissue repairs and higher with mesh repairs. And really the thing that we worry about the most with vaginal mesh is things like mesh exposure. So, a few words about mesh. We talked a lot about mesh for synthetic mid-urethral slings, but when it comes to pelvic organ prolapse, the conversation's a little bit different. The FDA in the United States had released a paper in 2011 that said that transvaginal mesh kits were not as safe to use, and trocar-based kits needed to be used with significant caution. I would say that in the right hands and properly placed, vaginal mesh can be very effective for treating recurrent anterior and apical prolapse, but it really needs to be used in the right setting, and it needs to be used by people who are well trained in how to place it and how to manage the complications. In the United States, when the trocar-based kits were taken off the market and restricted really to people that are fellowship trained, we've stopped seeing sort of the high mesh that was placed earlier. So I think it's something to consider, but again, requires training and understanding of the risks associated with it. So let's talk about the apical compartment. So as I had mentioned earlier, apical defects are loss of level 1 vaginal support. So that might present as uterine or apical prolapse or complete vault eversion. And uterine prolapse can be treated either with a hysterectomy and a uterosacral suspension, or you could consider a uterine preserving approach such as the hysteropexy. In general, the data behind hysteropexy is that it's not as effective. However, if you do have a patient who desires to preserve their uterus or is young and wants to preserve childbearing function, it might be something to consider. So I had mentioned the question of the apex when we were talking about a native anterior colporrhaphy, and it's not going to work if you don't address the apex if the apex is descending. So in this picture here, you can see that the cervix has descended towards the vaginal opening. So if you were to just perform an anterior or native tissue repair, you can see that the cervix is still here even when you're done. So if you don't address the apex, then your prolapse repair will fail. So, an isolated cystocele or a significant one is a rare thing, similarly with vault prolapse. So usually, if you have an advanced anterior prolapse, you typically need to address the apex. And similarly, if you have an advanced apical prolapse, most of the time you need to address the anterior compartment as well. So again, the apex is sort of the keystone of support, and if you don't correct it, you won't have successful outcomes. And this is an analogy I use with my patients a lot, that if the curtain rod is coming down, if you want to fix it, you're not just going to cut off the bottom of the curtains, you have to raise the rod back up. So I describe to patients that if the apex is coming down, we need to sew the top of the vagina up to something strong in order to fix their prolapse. So the vaginal surgical options that you have are a sacrospinous fixation or a uterosacral ligament suspension. So sacrospinous fixation is done by either through a pararectal approach that you can either do anteriorly or posteriorly through the vaginal wall. And sort of the hallmark of the surgery is to really identify the ischial spine. So here you can see with the finger, you're feeling the ischial spine, palpating this, and then clearing off the sacrospinous ligament from lateral to medial, and then placing sutures directly into the ligament. The things to be aware of when doing this, you can do this unilaterally or bilaterally, and you really want to make sure that you can reach the ligament safely. There's a number of different devices that can be used, Mia hook, the Deschamps ligature carrier, the shunt punch, or the Capio needle driver. I typically use the Capio needle driver, which is shown here, because I find that the slim reaches really well into the space and that I can control it and control the deployment of the suture without difficulty. So the things to counsel patients about that I worry about when I do this surgery is that the pudendal nerve and the neurovascular bundle run just posterior to the sacrospinous ligament. So depending on the placement of your suture, you have the potential of injuring these structures, which can either lead to bleeding or pain. You also want to be concerned about ureteral obstruction. Typically, if you have caught the nerve with your suture, patients will complain of sort of immediate coccygeal pain, and oftentimes that pain is so severe after surgery that they're unable to walk or move. If it is so severe, you could consider cutting your sutures to release it. But oftentimes, mild pain will resolve with a few weeks of observation. So one of the things you need to just sort of assess is how severe the patient's pain is. And if it is really severe and you're concerned you did injure the nerve, it may be worth cutting the suture, even within a few days after surgery. A uterosacral suspension is done by suspending the top of the vagina to the uterosacral ligament. So here's some photos showing that, schematic there. Essentially, you want to suspend the vaginal cuff to the ligament at the level or ideally above the ischial spine so that you can help reapproximate and preserve vaginal length. One of the things with this approach or operation to be very careful of is the ureters, as they run very close to the cuff, and so you want to be sure that you assess for ureteral kinking or injuries. So typically what I will do is I will place my sutures in the uterosacral ligament, and I will pull on the sutures and do cystoscopy to ensure that I haven't kinked the ureters. Once I've confirmed efflux, then I'll tie down my sutures. You can consider using permanent sutures for this surgery, and often people describe using Prolene or PDS for these sutures. So the optimal trial compared the two types of approaches, sacrospinous and uterosacral, in terms of outcomes. And you can see here that they had similar surgical success at 2 years, which was defined as absence of vaginal descent or prolapse beyond the hymen in absence of symptoms. So the other option for fixing apical prolapse is sacrocolpopexy. So this is placement of mesh around the vagina and secured to the anterior longitudinal ligament. So this is done by dissecting over the sacrum to clear off the anterior longitudinal ligament, dissection over the vagina to separate the vagina away from the bladder and the rectum. You then suture the mesh on both sides and suture the mesh to the sacrum, and then close the peritoneum. I typically always do cystoscopy to ensure that there's been no injury to the bladder or the vagina. And I do sacrocolpopexies robotically. However, you could perform this laparoscopically as well. The advantages of sacrocolpopexy is that you're introducing a graft, and so you're not relying on weak tissue, which helps restore strength in patients who have kind of significant prolapse. The other advantage of this surgery, similar to uterosacral ligament, is it suspends the vagina in a more anatomic position compared to sacrospinous fixation. So it helps preserve vaginal length and can be very good for patients that are sexually active. The mesh-related complications from sacrocolpopexy are low and considered acceptable. So this systematic review showed outcomes, and you can see here that it really favors sacrocolpopexy, but again, we have less long-term data with this surgical approach compared to traditional vaginal approaches. Here's another systematic review that looked at these studies, and the complications, including ileus and small bowel obstruction, were low. Mesh and suture complications were low as well, and there was really no difference in reoperation rate. So it can be a significant benefit colpopexy mesh makes up a very small percentage of this. So again, I think overall I would say it is a safe procedure to use and a safe application of mesh for pelvic organ prolapse. And sort of a final option to consider for prolapse repair is colpoclysis. So this is surgical closure of the vaginal canal. This is only appropriate for women who are not planning to be, and it says surgically, but I meant sexually active. And the way I always describe this to patients is that we're taking their vaginal length from being this long to being this short. So oftentimes patients are concerned about what their appearance would be, and I explain to them that the vagina looks normal from the outside, but it is now not suitable for intercourse because we've shortened the depth. This is a really good operation to consider in your elderly patients who might have severe prolapse. There's really minimal morbidity from it. It can be done under a spinal anesthetic with very little pain and blood loss. And it's due, the risks of the surgery are very low due to the superficial dissection that you're performing. Also, this has very high success rates. And I quote patients 95 to 97% success rate with colpoclysis. So in summary, when you think about pelvic organ prolapse, first always think about non-surgical options depending on the patient's degree of bother and their symptoms. If they are bothered enough and you feel that correcting the prolapse will improve their overall function, then think about whether they're best suited for a native tissue or vaginal repair versus an abdominal repair with mesh. I would tell you that the biggest thing I've learned in practice is that managing patient expectations is really important when it comes to prolapse. Patients need to understand what will get better with surgery and what won't get better. And so I will often clearly say to patients, your symptom of bulge, your symptom of splinting to go to the bathroom, the symptom of feeling that things are falling out, those things will improve with surgery. But the symptoms of overactive bladder or constipation, those things may not change with surgery. And I think setting those expectations is really important so that patients are then satisfied with the outcome of their surgery. All right, and I just want to say a quick thank you for this presentation to the SUFU Executive Board as they provided some of the content in regards to this lecture. Thank you.
That I will be giving today is on voiding dysfunction. So the objectives of the study, of this lecture, we're going to talk about how to evaluate patients that present with voiding dysfunction. And then we're specifically going to talk about treatment for overactive bladder and review some of the guidelines for treatment, bladder outlet obstruction, and pelvic floor disorders. So when a patient presents with incontinence and voiding dysfunction, as we were talking about some of the other lectures, I think important history taking elements are really sort of a key part of evaluation. And I think this is something that you want to remember also as you progress down the treatment pathway and patients respond to treatment and you are, again, evaluating them for recurrence and symptoms, because these behavioral elements play a huge role. So first I try to understand, when is the frequency occurring? What are people drinking? And I can't emphasize enough the importance of this, because oftentimes patients are consuming huge amounts of caffeine or alcohol, and that can be contributing to their daytime or nighttime symptoms. I try to understand when their incontinence is occurring, if it's urge or stress or overflow. I also ask about their use of medications. So this is another sort of important factor. If patients are on diuretics, they may be taking the diuretics at night, and that can be contributing to their nocturia. So again, trying to counsel patients that maybe they can consider taking their diuretics in the morning can play a role in management. And then you want to consider past medical history. I have often diagnosed patients with sleep apnea that present with significant nocturia or nocturnal enuresis. And so asking patients about whether they have sleep apnea, whether they snore, whether they're using their CPAP is very important. And then, of course, considering their bowel habits, because this can play a significant role in overactive bladder and incontinence. I think our pediatric colleagues do a very good job really assessing bladder and bowel dysfunction, but sometimes it's forgotten in the adult world, and that can be a huge contributor to patient symptoms. I also evaluate patients by having them complete an AUA symptom score to help quantify their symptoms. And then oftentimes if I'm struggling with understanding patients, habits, avoiding diarrhea can be very helpful to get a sense of what their bladder capacity might be and what they're drinking and when they're timing their fluid intake. Then physical exam, like we talked about with pelvic floor dysfunction, is again really important. Try to examine the patient's body habitus. On the abdominal exam, if sometimes patients will say they're not constipated, but I'll examine them and I can actually feel palpable stool in the belly, so that's important. And then in women, I examine for characteristics of vaginal atrophy, masses, and do a good exam of their pelvic floor musculature. So here's some pictures of things you may want to look for. So vaginal atrophy can definitely contribute to irritative voiding symptoms, and then examining for masses such as a urethral diverticulum that could be contributing. So part of my office evaluation, I will always obtain a post-void residual to make sure that we're not dealing with an issue of incomplete emptying or overflow incontinence. I typically will obtain a urine analysis and urine culture to rule out infection as a source of their voiding symptoms. In men particularly, if I'm trying to get a sense of whether there's an obstructive component, a uroflow can be helpful. And then in patients where sometimes a picture is difficult to tease out, whether it's a mixed or stress component or whether there's a neurogenic bladder component, urodynamics can be helpful. This can help evaluate for stress incontinence if you can get it on an exam, destructive overactivity. It can also help look for compliance. Help look for compliance issues and for bladder outlet obstruction. And at times I'll consider cystoscopy if I'm concerned about mass or obstruction. If they've had prior surgery, such as a sling surgery, I may perform cystoscopy to evaluate for mesh complications, or then of course for other urologic issues like hematuria. So here's a patient scenario, 65-year-old female. So this is sort of a common patient that I see in my clinic. So she comes in complaining of urgency and frequency. She feels like she never empties her bladder. She says she wears a few pads a day and says that they're lightly soaked. She does endorse upon questioning that she will have urgent incontinence. So on the way to the bathroom, she will leak. But she also describes leaking if she's just sitting there watching TV. She occasionally will leak with stress activities like coughing or sneezing. She drinks 2 cups of coffee a day and water. She also takes Lasix. She has a history of a hysterectomy with BSO and 2 vaginal deliveries. And on physical exam, she does note a vaginal bulge and she has a grade 2 cystocele. So there's a lot going on there. So based on what she's describing to me, I start with focusing on overactive bladder. Bladder. And so this sort of leads us to the SUFU pathway, and here is kind of a nice delineation of first and second line treatments. So as I mentioned in the history taking, thinking about first line treatments is really this initial counseling that should happen, talking to patients about modifying their fluid intake, thinking about pelvic floor muscle training, thinking about bladder training, and sort of assessing those habits. It is sort of shocking to me sometimes how many patients come from their primary care provider and have not really had this appropriate counseling. And I think a lot of it is because there's not that time. And so when they come to the urologist, it's the first time that someone has really asked them about some of their habits. So this is sort of an easy one that you can start with. Second line treatment is then to consider medications. And so we'll go in sort of in depth about the different types of medications that one can consider. And then we'll talk about third and third line therapies in a little bit later. So the pharmacologic targets for treating overactive bladder are the receptors throughout the lower urinary tract. As we remember, parasympathetics are what cause the detrusor muscle to contract, and there are more M2 receptors than M3 receptors in the body in general, but the M3 receptor is really what is responsible for causing detrusor contraction, and it is activated by acetylcholine as the receptor. The other receptors in the lower urinary tract that are targeted by our medications are beta receptors. So these are activated by the sympathetic mechanism or sympathetic nervous system. And beta 3 is what's highly concentrated in the detrusor muscle. And so activating beta 3 receptors relaxes the bladder smooth muscle. And finally, alpha 1 receptors are located in the urethra, and activating the alpha 1 receptor contracts the urethral smooth muscle. So this is kind of a nice diagram to help you think about where these receptors are located. So muscarinic receptors are in the detrusor muscle. Beta 3 receptors are also in the detrusor muscle. And again, parasympathetics guide the muscarinic receptors, which cause contraction of the bladder. And hypogastric or sympathetic system causes relaxation of the bladder muscle. The pudendal nerve is the somatic response that activates acetylcholine in the urethra. And then again, this is what causes urethral contraction. So most bladder medications that are used for overactive bladder are not purely selective for the lower urinary tract, which is why there are so many side effects from these medications. For example, there are significant or several M1 receptors in the brain, and so antimuscarinic medications can therefore have central nervous system side effects when used. So the side effects are often due to, again, the lack of selectivity of these medications. So in general, you need a higher dose of medications in order to actually inhibit the detrusor muscle than you do to affect the salivary glands. So thereby, the medications that allow us to treat overactive bladder then affect the salivary glands and cause dry mouth or cause constipation in other organs. So the two causes of overactive bladder medications are antimuscarinics and beta 3 agonists. So we'll first start by talking about antimuscarinic medications. So antimuscarinics range from tertiary to quaternary amines, and as we move down this list, we have increasing M3 selectivity, meaning that you have less side effects and more effect on just the bladder alone. So oxybutynin is probably the most commonly prescribed anticholinergic medication or antimuscarinic medication. And the reason for that is it was one of the older medications. And so at least in the United States, it's more readily available as a generic and tends to be cheaper. It is, a tertiary amine. It is non-selective, so it affects M1 and M3 in a greater effect than M2. You must be careful with this medication in elderly patients. It actually has a prolonged T half-life in elderly patients, and so it can cause significant CNS side effects. It comes in several formulations, so there's an immediate release formulation and an extended release formulation. Overall, if you can, I recommend prescribing the extended release formulation because what that does is it allows for a smoother kind of concentration time. With the immediate release, you get peaks and troughs of the medication, which then cause increased side effects like constipation and dry mouth. Whereas when you have a smoother curve of how the medication is metabolized, there are less side effects. It also does come in a syrup and transdermal release form as well. And sometimes the transdermal release is a little bit better tolerated for some patients. The other medication that I really use probably the most commonly for treatment of overactive bladder is trospium. And the reason for that is that it's a quaternary amine. And so therefore it has limited CNS penetration and typically causes less of the mental side effects and confusion that you see in the elderly. There were recent studies published in the last 6 to 8 months that showed significant risk of dementia with anticholinergic medications. And due to that, I really have gotten away from prescribing any of the other anticholinergics except for trospium, as this is the one that doesn't cross the blood-brain barrier. What's complicated about this medication is that the immediate release form has to be dosed twice a day and it has to be taken on an empty stomach. So this can be really hard for patients to be compliant with. And if it's taken with a meal, it reduces its absorption significantly and doesn't work. There is an extended release formulation of trospium, which is easier to take and can be taken once a day. So in this meta-analysis looking at all antimuscarinics, they found that they did increase incontinence episodes significantly. The exception was tolterodine, which didn't really change, immediate release formulation, which had no change. They did reduce frequency significantly, and they reduced urgency significantly. When looking at the specific medications, oxybutynin immediate release, patients were more likely to stop using it due to the side effects profile, particularly dry mouth. And that goes back to the description I was saying about the immediate release form having kind of these peaks and troughs when it's being administered. Solifenacin and darfenacin were more likely to cause constipation than others, and solifenacin was more likely to cause blurry vision. And with all of these medications, you do have the risk of cognitive dysfunction. So again, I urge you to think about that with caution in the elderly. So side effects like we talked about are dry mouth, near vision blurriness. Some patients experience tachycardia and drowsiness. Gut motility, so constipation is a huge problem with anticholinergic medications, and some patients can have orthostatic hypotension. So the second class of medications are beta-adrenergic agonists like mirabegron, which is one of the newer, would be sort of the newer medication for overactive bladder. It's in the United States, it's currently the only FDA-approved beta-3 agonist. I realize that, you know, in Europe and in Asia, you may have other formulations of this. But the way that this works is it increases bladder capacity during filling. So like we talked about, it works on a beta-3 receptor to relax the bladder muscle, which increases the capacity. The contraindications for this medication are renal disease and hepatic impairment. And I would say overall, this is a very well-tolerated medication. Adverse effects are fairly low. GI constipation, dry mouth, and nausea are still fairly low. I would say nausea is probably the most common side effect that patients report to me. And then the other cautionary use with this is that it can cause an increase in heart rate and blood pressure. In patients that do have higher blood pressure and those that I'm concerned about it raising blood pressure, I will often have them return for a blood pressure check in 1 month to ensure that the medication isn't causing an adverse effect. But as long as the patient's blood pressure is well controlled, even if it's well controlled on medications, this can be safe to use. This study showed sort of the change in effects with mirabegron, and it was found to be more effective than or at least similarly effective to most of the anticholinergics. Solifenacin was noted to be more effective. But again, as I mentioned, it has less side effects and doesn't have the same CNS sort of cognitive side effects that we worry about with anticholinergics. So we're finding that our usage of mirabegron and beta-3 agonists is increasing significantly, especially given these side effects. The other consideration is combination of therapies. So the bedside trial looked at combining solifenacin and mirabegron together as a treatment for overactive bladder, and that was found to be more effective and well tolerated with less side effects. So now looking at the clinical pathway, if your patient is continuing to have refractory symptoms after behavioral modifications and medical management, then that's the time to consider third-line therapies. And these include chemodenervation with Botox or botulinum toxin, posterior tibial nerve stimulation, and sacral neuromodulation. So with botulinum toxin A, the way this works is it blocks the release of acetylcholine from the motor nerve endings, which causes hypocontractility of the detrusor muscle. So essentially it's causing sensory impairment of the muscle. It was FDA approved in the United States for overactive bladder in 2013. And what's really nice about this procedure is you can do it in the office. So the way that I do this procedure, and this is a video from one of my colleagues, Dr. Cameron, who performing Botox in the office. But what we typically do is we instill lidocaine into the patient's bladder. We let it sit in the bladder for about 20 minutes, and then we go in with a scope and inject Botox into the detrusor muscle. It's very fast and easy to do. So you'll see here she's going in with the small rigid scope in a woman and injecting using a rigid needle. And typically I do 10 injections of 1 cc. So I usually, if I use 100 units of Botox, I dilute it into 10 cc's of saline and inject 1 cc in each location, sort of spread along the posterior bladder wall. What's important about the technique is you want to make sure this is an intradetrusor injection, so you can see that when the Botox is being injected, you're not getting a submucosal bleb, but really that the Botox is actually going into the muscle, and that's really what's going to make it the most effective. And as you can see here, this can be done very quickly, and so it's usually very well tolerated with patients, particularly if you allow the lidocaine about 20 minutes to instill in the bladder. So the efficacy of Botox, it has been shown to be 2 to 4 times more effective than placebo. It has about a 6 to 12 month average duration of therapy. I have patients that I inject every 3 months, and I have patients I inject once a year, so, and everywhere in between. The main side effects that I counsel patients about is some patients can have some pain or discomfort, and there's always a risk of urinary tract infection with introducing a cystoscope and hematuria. But I would say those are all probably 5% to 10% for risk of all of those. The biggest risk that you really need to counsel patients about is the risk of developing urinary retention that requires intermittent catheterization. And I would, based on the data that has been published, that rate is 3 to 5%. This is sometimes probably the biggest holdup for patients not wanting to undergo Botox is due to their fear of developing urinary retention. So the next therapy to consider in patients with refractory symptoms is posterior tibial nerve stimulation. And the way that this therapy works is by stimulating the tibial nerve. The tibial nerve is made up of nerve roots from L4 to S3, so it's a mixed sensory and motor nerve. And the way that this therapy came about is this was found through an acupuncture point that was used to inhibit bladder activity. And so extrapolating kind of from traditional acupuncture techniques, it was found that if you stimulate this nerve, similar to the way we do sacral nerve modulation upstream, that you could provide afferent stimulation that could override the signals that are going to the bladder to contract. And so that's kind of the theory behind how the nerve stimulation works. What's nice about this therapy is that it's really minimally invasive, so patients usually tolerate it very well, and there are really no side effects from it. But what I tell patients is it's either going to work or it's not going to work. And the main downside of this is their commitment of time. So in the United States, we do this in 12 weekly sessions for 30 minutes each. That's the way our insurance covers the treatment. And after 12 sessions, if they've shown efficacy, they continue once a month maintenance sessions. Again, depending on where you practice, you may be able to alter the schedule that you provide these stimulation treatments. So this is the hookup that we, one of the types of devices that's used, this one is Urgent PC. It's also made, there's also another device for PTNS made by Medtronic. This one's made by Uroplasty. So, you know, there's several versions of this out on the market, but essentially you place the needle at the posterior tibial nerve. I usually feel for the medial malleolus and go 3 finger breaths above and place the needle. And it's kind of right in that divot of skin between the bone and the Achilles tendon. And I would say the common mistake in placing this needle is oftentimes people don't place the needle deep enough. And so sometimes you need to advance the needle in a little bit more in order to really get good stimulation. Also, it keeps it from falling out when you attach the device. And then once you turn it on, you go through a test phase and you ask the patients, they should feel sensation up to their big toe if you're in the right location, sometimes in the arch of the foot. And you want to increase it to where they feel the stimulation consistently, but they're not uncomfortable or in pain, because they will have to sit for 30 minutes. And if the foot is cramping or painful, they won't be able to tolerate the treatment. So in randomized trials, PTNS versus anticholinergics, it showed an 80% improvement in global assessment of response, so in patients' perception of their response compared to anticholinergics. And then in a double-blind placebo trial, 70% of patients had at least 50% improvement in their symptoms, which is what all of the OAB trials would consider a success. And there was improvement overall in incontinence episodes. I would also extrapolate that we currently at Michigan are doing a study looking at PTNS and MS patients with multiple sclerosis, but there are some small studies that have shown that it can be effective for patients with neurologic disease that's contributing to their overactive bladder. And then the third therapy to consider is sacral neuromodulation. So this is done by placing a time lead at the S3 nerve root. It can be done in 1 or 2 stages. Typically, we're using sedation or monitored anesthesia care. It's a minimally invasive procedure, and in the United States, it's approved for overactive bladder, non-neurogenic or non-obstructive urinary retention, and fecal incontinence. And there are some expanding clinical indications to consider this for, including neurogenic bladder and pain. So this is sacral neuromodulation. So this device is made by Medtronic. There are other companies that also are making a device, including Exonics, which recently has been marketing their device on the market, as well as Nuvectra. So there are, several companies that make a neuromodulation device. And the way that this is placed, you place it through the S3 foramen, and then the lead should sort of fan out along the projected course of the nerve root. If you've had successful placement, when you test the electrodes, you should have a response at less than 2 volts along each electrode for it to be sort of ideal placement. And this is confirmed using fluoroscopy and looking for motor response in the operating room. In the initial studies that were done in the United States, 60% of patients that were refractory, so these are patients that had failed all of the first and second line therapies, had at least 50% improvement, with consistent improvement at 5 years. Some of the prior limitations that we had with neuromodulation is that the prior devices were not MRI compatible, so this significantly limited its use in patients that had back problems and neurologic disease. And then the battery life is, on average 5 years. So patients will require subsequent procedures to change their battery. One of the exciting things is that there is a new lead that is now available that's MRI compatible. So Exonics lead is MRI compatible, and Medtronic also just had a lead that was approved that's MRI compatible, which I think is going to greatly expand our usage of this technology, because we can now use it, expand its usage in patients with back problems and neurologic disease. So this is sort of a really exciting thing. And actually, the FDA approval just happened this week in the United States. So this is an exciting time in the era of neuromodulation. So I put the question here of prolapse repair, and we talked in the last lecture about pelvic organ prolapse. And patients always ask, well, is my urgency and frequency going to get better when you fix my prolapse? Studies have shown that 20 to 40% of patients may still have persistent symptoms even if you fix their prolapse. And there's really no correlation with the degree or the compartment. So I always tell patients it may or may not improve, and that they need to be prepared for the fact that we can fix their prolapse, but they may still require additional management such as medications or Botox or PTNS to treat urgency and frequency if that still persists. I typically wait 3 months after prolapse repair to initiate any of these treatments because I think it takes about 3 months for the bladder mechanics to kind of get back to normal before you can really assess whether patients might require something additional. And so this is, again, kind of talks a little bit about what might happen is that you have some obstruction that's occurring from the prolapse, which over time is causing changes in the detrusor muscle and the reflexes, leading to detrusor overactivity. But that doesn't always resolve when you fix the obstruction. And that's similar to when you fix bladder outlet obstruction in males as well. So here's a sort of male perspective. 55-year-old male presents with lower urinary tract symptoms that occur daily and are worsening. You can see here he does have some room for behavioral modification. He's drinking a fair amount of coffee, which you could probably reduce, and he does have some constipation. So bladder outlet obstruction in men, we always think about prostatic hypertrophy. You can also think about primary bladder neck obstruction. And then women, I always think about whether they have a component of obstruction due to a history of a sling or a bladder neck suspension. So I'm not going to spend a lot of time talking about surgical management, but we'll just review medical management of BPH and bladder outlet obstruction. So really the main thing I want to focus on is we've been talking about receptors in the lower urinary tract, and there are alpha receptors that are located in the prostatic smooth muscle and at the bladder neck in women. And so by blocking these, you can reduce tension and improve obstruction. And you can also consider the use of alpha blockers in women that have non-iatrogenic obstruction and present with retention. So these are the different types of alpha blockers, and you have non-selective to more subtype selective for the urinary tract. So side effects, of course, can be dizziness, hypotension, retrograde ejaculation, and those are things to counsel your patients about. So I think this is a really important concept is people are always concerned in men that anticholinergics cause more retention if they have bladder outlet obstruction. And there was a really great study in 2006 that looked at men that had lower urinary tract symptoms and prostatic hypertrophy and randomized them to anticholinergics, alpha blocker, tamsulosin, placebo, or combination therapy. And combination therapy showed significant benefit. And there were really no side effects of retention. So I think that this is an important concept that in patients that have bladder outlet obstruction, if they have significant urgency and frequency components to their symptoms, consider the concomitant usage of an anticholinergic or an antimuscarinic, as that may really improve their symptoms. You may want to use this with caution in patients that have a very high PVR. So I would say in patients that have a PVR of more than 250 to 300 cc's, you may want to think twice about that. But otherwise, if they have a fairly normal post-void residual and are not showing signs of retention, it's very reasonable to consider combination therapy. And then finally, I would say that when it comes to voiding dysfunction, you want to think about pelvic floor disorders like prolapse, pelvic floor dysfunction, and pain. If these issues are present, patients may require multimodal therapy, and so you may want to think about physical therapy in these patients and consider whether they need additional behavioral management. So these are some references for your usage when you're thinking about this treatment. And in summary, I would just say, again, think about sort of the algorithm for treating overactive bladder and ensuring that you're thinking about behavioral modifications at each step. Thank you.
So, learned audience, to keep attention in post-lunch session is very difficult. Although still there are more than 100 participants in this session, as we are running shortage of time, and there are few questions, only 3 questions we see here in the chat box. One is, what are the long-term effects of Botox injection in OAB? You have to repeat the injection 12 to 18 months later. And next question is, how to differentiate pelvic floor muscle dysfunction and neurogenic bladder? Another question. And there is another question, is there any difference between neuromodulation and bladder pacemaker? So I think Dr. Priyanka Gupta has nicely elaborated his lecture in compiled way in 30 minutes, 4 lectures, that we understand everything. We don't understand everything in one hearing. So I request the BAUS to send these lectures video to every member of the BAUS and also the residents, so we hear it repeatedly and we clear our conception about these topics. So today's discussion, we only see the icebergs of the female urology. So I request our young urologists to concentrate in this field and help our mother and sisters to combat this disease. In Bangabandhu Sheikh Mujib Medical University, there is a fulfilled unit of female urology and andrology, and another is neurourology. We work every aspects of neurourology and female and andrology. So I think government sector come forward to create this post, and thereby our urologist can work in this line. With these few words, I thanks BAUS Executive Committee and residents and who hear this webinar, and also the members of the Urology Society to attend this webinar. As there is shortage of time, I cannot want to discuss, repeat the similar topics which Priyanka discussed nicely. So thank you. I now hand over the mic to our scientific secretary, Dr. Sudhir Dasgupta.
Thank you, sir, for summarizing the session. Now, the time for vote of thanks, as Dr. Mohammad Shafiqul Alam Chaudhuri, according to program schedule, but he is now busy in a meeting. So I request recent Secretary General Dr. Tawhid Mohammad Saiful Hossain to give vote of thanks to the respected members and to the moderators for giving their busy time and to make this session course successful. Dr. Tawhid Mohammad Saiful Hossain.
Thank you, respected participants, viewers, and I saw in the participant box from the Asian Institute of Nephrology and Urology, probably Professor Malikarjuna C was with us to see this webinar. Thank you very much, sir, for joining with us. And I immensely benefited by this today's talk. From morning to till almost evening, and I am very glad to see the enthusiasm of the participants and viewers from morning to till evening. So hope our junior urologist and our trainee, that is our residents, definitely will be encouraged by seeing this 2 days session, by taking the responsibility of these three neglected subspecialty of urology, particularly female urology, andrology and infertility, and also the pediatric urology. So Bangladesh Association of Urological Surgeons Executive Committee, me, myself, and other executives with scientific subcommittee is trying hard, even in this unforeseen time of COVID-19. We are trying to disseminate the knowledge. We cover almost all the sectors of the urology during these 5 to 6 months by webinar, by BAUS ourselves, on also in association with the Urology Society of India, Society of Urology Internationally, Urology Association of Asia, SARC Association of Urological Surgeons, and particularly another 2 institutes like even Organ Transplantation Society of India, and also the 2 institutes like Muljibai Patel Urology Hospital and Asian Institute of Nephrology and Urology. So we are immensely benefited by joining this webinar. Hopefully we'll do more and more if this COVID-19 will persist. So I seeking your active support from the members and residents. Please support with us, and we'll give you the more better activities. And particularly, I request all our members and the residents to enrich our collaboration and ongoing friendship with the American Urology Association. Please renew your membership of AUM membership and be more and more new member of the American Urology Association. And please renew your membership, particularly resident also, so that we can continue our this relationship and friendship. And I must give thanks to AUA leadership, particularly AUA Secretary John Dansted and the Oshim Shukla, Assistant Secretary of this region, and the official of AUA, Laurie, Lacey, and so many. and particularly today's speaker, Ashim Shukla, Taviz Kohlar, and the Priyanka Gupta. From the core of our heart, extreme congratulations and heartiest congratulations for their excellent talk and deliberation. And I must thank to our today's moderator, particularly Professor A.K.M. Khurshidul Alam. From his busy schedule, he gave the time at the evening time. And thank you very much, sir. And Professor Nurulhuda Lelin, he was so busy man. He's the director of the National Institute and so other administrative work. In spite of that, he joined with us and give his time. And Professor Istiaq Ahmed Shami, one of the pediatric urologists of this country. And thank you very much, sir, for your excellent moderation. And your moderation and your concluding remarks enriches our today's webinar. Thank you all participants. Without your participation, it was not possible to make it successful. And I particularly pay my homage and respect to my senior teachers, particularly all the past presidents like Professor M. Wahab, Professor M. Salam, Professor A.K.M. Anwarul Islam, Professor S.A. Khan, Professor Rafiqul Abidin, and all the past secretaries of the societies. Thank you very much. Thank you very much. And tomorrow we have the session. Dr. Sudip Das Gupta will announce the tomorrow's session. Thank you very much. Thank you and see you again. Stay safe, stay blessed, and keep healthy. May Allah bless us all. Assalamu alaikum.
Thank you, Mr. Secretary General. And before that, I would like to remind all the residents that tomorrow we have a program for you, and it will start at 10 a.m. and at 9:45, our President and Secretary General will give their address to you. And there is a change in this program, that is at 10 a.m. Professor Mizanur Rahman from GMC is busy with preoccupation. So at that time, President Dr. Habibur Rahman Bilal has given his consent to continue the program, and at 11:30 a.m. Dr. Mizanur Rahman will join us. And thanks to all of you for your presence. And tomorrow, the residents must join the program, because without your participation, the program will not be successful. And now I request Professor Habibur Rahman Bilal to conclude the session. And from the Scientific Committee, BAUS, I Member Secretary Sudip Das Gupta, thanks all of you, and saying goodbye to you, and see you tomorrow morning. Thank you very much. Sir, we cannot hear you. President sir, we cannot hear you.
Sir, unmute karen. Resident sir, unmute karen. Yes.
Hello?
Now we can hear you. Yes.
শোনা যাচ্ছে?
এখন শোনা যাচ্ছে স্যার।
আচ্ছা। Thank you to Dr. Sudip Gupta, Secretary, Scientific Committee. Assalamu alaikum. Good afternoon, everybody. Honorable Chief Guest, dear participating members, and dear residents. Hope you have enjoyed the lesson course. We have highlighted especially carcinoma prostate, pediatric urology, andrology, and infertility, female urology. Resident are our next future. So it is our desire that resident will be up to mark. The aim of BAUS is to make residents as well as standard. We think residents are benefited from this course. We are thankful to our learned speakers from home and abroad, and our 3 moderators, and for making the course a lovely one. We are very sorry for any inconveniences. There are some limitation in this pandemic situation. Hopefully, we'll make a successful and gorgeous program after pandemic over. May Allah bless us. We are grateful to American Urological Association for kind and generous support for the development of urology in Bangladesh. Lastly, I must thankful to all the EC members, our scientific committee, especially our dynamic Secretary General for making a successful lesson course. Goodbye to everybody. Allah Hafiz.
Thank you, Mr. President. So we are waiting for tomorrow morning. Hope you all will stay safe and wish your good health during this pandemic period. Tomorrow we will meet again. Thank you very much.